So I think slightly touched upon this case was. So can we have, first we'll start with Dr. Anand, multimodal, multicolor imaging.
So I think based on what Manoj said, this probably could be a nevus kind of thing. This reddish, there's no edema over that. There's no greenish stuff.
Okay.
So looks like a well-defined lesion, possibly.
So why is it reddish?
Well, for one, I think it's the RP which is slightly disturbed, or there's something under that which is, showing up. I'd rather have to see the other three, infrared, green, and blue to make a more educated guess. But the push on the RP, I think, is leading to that discoloration.
So just to touch what Manoj said, there are three modalities, three laser lights going up. The red goes to the deeper, so any disturbance in the deeper layer picks it out as a well-delineated part, differentiating a normal versus abnormal pathology, basically. So this is the AF, which we haven't touched. Dr. Darius, would you like to comment about this?
Yes. So we can see a lot of mottling of the pigmentation. And normally AF, what they say is the area which is whiter or hyper, it shows more activity of fluid, and the area which is dark, of course, shows the dead RP. So this means it's quite a chronic kind of lesion. And I think this is important to do along with the multicolor. What I found was quite scary with that is that Dr. Manoj in fact showed that case with those red dots. And so I have in fact a question for you. When you see those red dots, you must be very careful, because you always think of hemorrhages when you see red. And actually when you see the actual color photo, you see it's actually black pigmentation. So I always get puzzled when I get only a Heidelberg photo done. Are we doing justice to this patient, or should we also get a flash photography?
So the basic tenet is that you never assess the patient based on one image. So if you know and you've trained yourself to understand that red does not necessarily mean a hemorrhage, then every picture of a
actually
Heidelberg
difficult for us to do, because we have to retrain our minds to.
This is pseudo color, yeah.
Pseudo color imaging. So
This
one thing interesting, I'll just flip through the images. Larger lesion, smaller lesion. So you have a larger thing picked up on the multicolor imaging, and a much smaller thing picked up on the autofluorescence, which is quite an interesting finding over here. Autofluorescence, in one word, is called metabolic imaging. It defines the health of the RP on a metabolic level, basically. Irritated RP is white, dead or loss of RP is black. So this is your ICG picture. Dr. Shane, would you like to?
ICG imaging showing that is 3 minutes and
1 minute 3 and
1 minute and 3 minutes.
3 minute 51.
Yeah. So the central area shows a hypofluorescence in the macular area, and surrounding edge shows a little hyperfluorescence as well. So what about the later stages of the angiogram?
Yeah, I think this is at 20 minutes.
20 minutes. Okay. So there's no obvious polyp seen. There is no obvious occult membrane as well. And the edges shows little hyperfluorescence, so pronasally.
Okay. So it's very unfair to surprise a person with an ICG or a thing, but that was pretty well said. So, and probably nowadays you think that you don't need anything else, you need only the OCT. So this was the OCT picture. So can Dr. Anand?
It looks like a nevus. There's a push from below, and it's pretty large. The whole thing, this entire shadowing out there. The RP is pushed up. How much is it? 400 something.
Yeah.
So yeah.
Would you like to
That's my
comment
first
about this
instinct.
and how it corresponds to the previous slides we saw?
Yeah, so that's what that RP disturbance is what I was saying. Something is pushing the RP, and that is leading to that reddish discoloration. That's what I would say. So my differential still, I think, is probably a nevus. Okay.
So now.
Yeah. You had to put that in. Yeah. So then you'll have to say
everything's going perfectly according to Q. Okay.
Yeah, now things change a bit. Yeah.
So, yeah, Shane, please.
Many times I've noticed that some of the occult membranes doesn't highlight on ICG, and you might pick it up on OCT and you treat it and it responds, but it doesn't. It will not be evident on ICG.
Okay. So, Dr. Anand, are you wishing for an OCT angiography now? Okay.
But I just like to look for a conventional fluorescein angiography.
Let's see if I
That
have
would
it.
be
No,
fine.
I don't have it. I have this. So what do we see here? The rise, please.
So in the third, which is we are seeing right in the center.
Yeah.
What is looking like, and so it could be. I mean, we should not comment like that, but yeah, it could be some sort of a choroidal vascular membrane, or looks like a polyp, in fact, in this picture actually.
Okay, I'm going to ask you just one question. Did we actually need to do this? You had a nevus-like lesion with an overlying PED with fluid. Did you have to think that you needed something else to say it was a neovascular process or not? Clinical question. Did you need to prove it on ICG? Did you need to prove it on OCTA to say you had a neovascular process?
Since you have the structural OCT showing you that there's a RP elevation, which is like a type 1 membrane, and there is some fluid, so obviously you're then thinking it's a secondary CNVM, having seen that large lesion in the choroid. So you know that there is something there. So you would like to know activity. So I would definitely like to do the conventional angiography, as I mentioned. We like to know if it's leaking, if it's something which needs patient. What is the history? Patient was symptomatic or just asymptomatic?
Actually, you're not giving us any history. The
Yeah,
vision, fluid.
This is like
basically imaging symposium, so it's fine. I'm allowed to do that.
pretty unfair.
My question is, if there was a CNV, why was it not picked up on ICG? And I always wondered why these small CNVs are not picked up on
That's a
ICG.
really nice question.
Mm.
Dr. Ashish, would you like to give us a...
No. One reason for that possibly is that this the choroid. You see that entire. If you can you just show
Go
that
back,
thing? That entire lesion. I'm presuming it's a nevus, has pushed out all the choroidal conventional vessels away. So there's no way that ICG dye is reaching that spot. You understand? Or probably very minimal. So otherwise you should have seen pooling. He's even showed us the very late frames. So the thing has been there for such a long time. It has probably killed all the choriocapillaries out there, and that's why you see it as black. It's hypocyanescent in the center. So there is hardly any choriocapillaries out there at all. So this is actually pushing beyond where the RP would come.
And
So it's completely pushed everything out. So that's why the ICG dye is not reaching there.
one
what
clue
would-
you can see is here is that there is
Yeah.
no lumen here.
It's
There is
only-
a very compressed
Yeah.
stromal choroidal tissue.
so everything is
lack
just
of-
stroma there now. There's no vascular lumina.
Yeah, that's exactly what I was going to
Yeah.
In
So
OCTA, we see a neovascular process.
Yes.
see, OCTA is a generated image. How it generates it, we do not know. That is not there. You can actually before this bulk motion artifact technology came in, people were getting all sorts of images when the patient moves their head. Even it's basically looking at phase difference. So that I would put it slightly on the back burner. Like I said, it's still version 2. But this is why this is not leaking on the angiogram. I would like to see the fluorescein to see if there's leakages. That was
Unfortunately, we're doing only advanced imaging today.
So no.
Okay.
old
So-
is gold. Old is
So,
gold.
okay, I think
Yeah,
that's
I think
about
we
it. The NFAS doesn't show anything much regularity. So I thank you all for coming, and I hope you enjoyed the imaging session today. Thank you.